culture, social equity, evaluation, international relations, politics, and public administration. She's a recipient of the 2020 Natural Hazard Center Quick Response Research Projects in U.S. territories for her project Frontline Government Workers, an assessment of burnout and quality of life in the U.S. Virgin Islands following disasters. Our second speaker will be Sabina Lim. She is a Vice President and Chief of Strategy for Behavioral Health for the Mount Sinai Health Systems and a Professor of Psychology at the Icahn School of Medicine at Mount Sinai. Dr. Lim oversees clinical, financial, and administrative performance of the behavioral health services across the Mount Sinai Health System, and is also the primary lead in population health risk-based pilots and initiatives for behavioral health populations within the Mount Sinai Health System. She's received numerous leadership and advisory positions and has presented regionally and nationally on new behavioral health care delivery models and behavioral health integration in opioid epidemic. Tom Kirsch is a professor and director of the National Center for Disaster Medicine and Public Health at the Uniformed Services University. Dr. Kirsch has responded to or conducted research in disasters, including Katrina, Sandy, Harvey, and others, including earthquakes in Chile and Nepal, the Ebola epidemic in Liberia, and the New York City 9/11 terrorist attacks. He is globally recognized researcher and an educator who has lectured extensively worldwide and taught numerous courses in disaster health and public health. He's also worked at numerous federal agencies, including CDC and FEMA, and supported the World Health Organization and PAHO. I should let you know who I am. I'm sorry for that. My name is Robin Solar. I am the Associate Director of the Center of the Office of Applied Research in the Center for Preparedness and Response in the Centers for Disease Control and Prevention. And I'm really pleased to present Dr. Kula Francis to you with our first presentation. Please.
Thank you. Thank you for having me. I would like to thank Dr. Lori Peak and all of the organizers of the 46th Annual Natural Hazards Workshop for their focus on these issues that are of such importance to the world that we are all sharing. Again, my name is Kula Francis, and I am an Associate Professor of Political Science at the University of the Virgin Islands. As the title of the plenary is Burnout, Mounting Pressures and Workforce Shortages in the Age of Extremes, my presentation today is entitled Overworked, Overloaded, and Overextended, Burnout and Frontline Government Workers in the United States Virgin Islands. Based on the World Health Organization, burnout is defined as a condition occurring due to workplace stress that has not been successfully managed. It is characterized by three factors. First, feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, and reduced professional efficacy. With that definition in mind, let us turn to the Virgin Islands, the small US territory that is roughly 900 nautical miles from Miami, Florida. Due to the location of the United States Virgin Islands, the threats of disasters to the territory is significant. Located in the northeastern Caribbean, the United States Virgin Islands is in the path of many tropical weather systems and hurricanes. It also is at risk for earthquakes due to its location on the Earth's surface plates, where it is less stable. Additionally, due to fault ruptures beneath the sea, the tsunami risks are also higher. On September 6, 2017, Hurricane Irma made landfall in St. Thomas and St. John in the Virgin Islands, bringing catastrophic devastation with winds gusting as high as 165 miles per hour. Within less than 2 weeks of that, On September 17th, Hurricane Maria destroyed most of the island of St. Croix with wind gusts of up to 172 miles per hour. Entire neighborhoods were destroyed. The islands were left completely without public utilities, communication. Many residents were without water, food, shelter. In some cases, residents were without power for more than 4 months. The two main hospitals were deemed inoperable, with patients having to be airlifted out of the territory as their only consequence for medical survival. Airports were destroyed. Regardless of your economic status or social status, living on the island required support and services for human existence. Still, in the process of recovery from these major hurricanes, COVID-19 introduced additional challenges to the US Virgin Islands, as it completely closed the main source of revenue, which is tourism. Hotels, cruise ships, tourist attractions, restaurants, transportation services all suffered severe economic losses. Additionally, the introduction of COVID-19 also threatened the health and safety of the population of the Virgin Islands, many of which are considered society's most vulnerable, such as children, elderly, and persons with disability. In the face of disasters, societies turn to frontline government workers to ensure that public services are accessible and available. Oftentimes, however, we forget that these very same employees have undergone the same disasters and require the same services and assistance as other residents. Nonetheless, after Hurricane Irma and Maria devastated the US Virgin Islands within a 2-week timeframe, its citizens found themselves reliant on public personnel from an array of government agencies. As COVID-19 surfaced, these frontline workers were required to keep an adversely affected population safe and secure. Despite the threats from disaster, frontline workers in the USVI continue to protect and secure the well-being of the populace. The impact of burnout on public health in the Virgin Islands is significant, considering that 30% of the employed in the United States Virgin Islands are government workers. Of that figure, almost half are frontline workers. Another major role of location on affecting burnout is the fact that the remoteness of the island does not allow for nearby cities, states, or even countries to quickly or continually send employees to assist in times of need. Many agencies, including the Department of Human Services, hospitals, and police departments, face critical staff shortages. As a result of COVID-19, staff shortages have affected local budgets and operations. During the Virgin Islands legislative hearing, Commissioner of Human Services, Kimberly Causley Gomez, noted that there has been a shortage of employees in administering programs such as Medicaid and SNAP. She also stated that this is negatively affecting the efforts of current staff. She also noted that they are very dedicated and professional, but that they are limited in effectiveness due to staff shortages. Continuing on, she noted that many management staff were carrying caseloads and filling essential frontline roles or filling essential frontline roles that were vacant. These shortages lead to limiting much needed management, administrative oversight, policy, procedural activities, and updates that directly affect service provisions and federal compliance. The shortages can also threaten the funding of affected programs and their future implementations. The mounting pressures also added with limited workforce increased additional uncertainties for the current and future preparation of the Atlantic hurricane season, which started on June 1st. With COVID requirements, sheltering and other emergency response units are not preparing in the event that new natural threats develop. These issues make the concerns of burnout a major one in the Virgin Islands. Because of the critical concerns of burnout in the US Virgin Islands, my colleagues and I have been conducting research that look at these frontline government workers and the level of burnout, as well as quality of life in recovery from Hurricanes Irma, Maria, and COVID-19. These disasters have caused havoc on the entire community. However, the community turns to the government for basic care and needs. As a result, frontline government workers endure additional stresses during these events due to the nature of their job. Our research examined frontline workers from various government sectors in the US Virgin Islands. We defined frontline workers as public sector personnel who have a direct role in providing to the needs of citizens through public services. Specifically, we looked at the level of burnout and quality of life of government workers from the following agencies and departments: the Virgin Islands Department of Human Services, the Virgin Islands Police Department, Virgin Islands Territorial Emergency Management Agency, Department of Planning and Natural Resources, VI Fire Services, Department of Licensing and Consumer Affairs, Bureau of Motor Vehicles, Schneider Regional Medical Center, and the Governor Wang F. Louis Hospital. The significant research questions that we looked at were: is there a difference between burnout and professional quality of life experienced by frontline workers in the US Virgin Islands during Hurricanes Irma, Maria, and COVID-19? Second, is there a relationship between burnout and professional quality of life experienced by frontline workers in the Virgin Islands during Hurricanes Irma, Maria, and COVID-19? And finally, our qualitative question: considering post-disaster job experiences, what measures do frontline workers feel could have been implemented to reduce burnout or improve quality of life? To answer our research questions, we utilized two survey instruments: Maslach's Burnout Inventory and Professional Quality of Life ProQual Survey. Based on t-tests, there were significant difference between burnout following Hurricanes Irma, Maria, and COVID-19. Based on factor score correlation of both Hurricanes Irma and Maria, as well as COVID-19, there was a strong relationship between emotional exhaustion and burnout. The Hurricanes Irma and Maria model showed strong relationships between emotional exhaustion, secondary traumatic stress, compassion, and personal accomplishment. On the COVID-19 model, we saw moderate relationships between emotional exhaustion and secondary traumatic stress, burnout and secondary traumatic stress, and depersonalization and emotional exhaustion. The qualitative analysis yielded several emerging themes. Survey participants noted need for additional psychological and emotional support, need for additional supplies, organizational compassion and understanding, and additional time for family and rest. To quote one respondent as it relates to Hurricanes Irma and Maria, officers needed a call center set up where family members could go for assistance in making contact with the employee. While on duty, there is no way to know if family is safe. Also, food supplies should be provided since there is no opportunity, especially in the face of a hurricane, to purchase food or find anything to eat. As per commentary made concerning COVID-19, one survey participant noted, parents and grandparents are forced to choose between coming to work or risk losing their job because daycares and schools weren't open. Supervisors without children or independent children were not amenable to frontline workers who have young children. Based on our findings, we know that all disasters impacted employees, although in different ways. Government employees are not affected by all disasters equally. We also found that each disaster came with its own challenges. Although agencies may have guidelines and procedures in place for disasters, they must be flexible in the manner of care and understanding of their employees' situation. To minimize burnout, we believe agencies must consider reduction of overtime and or hire additional temporary workers to minimize overload on employees. They must acknowledge any accomplishments through disasters as much as possible. Employees need to know that their work is appreciated. They must offer additional channels of communication so that employees are able to convey emotions to supervisors when levels of stress seem unbearable. Resources must be invested in promoting mental health in terms of assessment and research, prevention, support, including work and family-based, and treatment. We recommend that agencies create collaborations with governmental organizations to develop disaster mental health plans that ensure frontline workers are provided with psychological and emotional support. We also suggest the creation of specialized time and location for employees to receive necessary disaster services for themselves: healthcare, food, water, clothing. Although allow personnel to create needs and or wish lists of services and resources that they need. Again, they too have went through these same disasters. There needs to be organizational compassion and understanding, contact to mental health direct services, supplies, additional time for rest, as well as inspirational and motivational activities for boosting employee morale. In closing, I will end with the story of Sam the sailor, a name mentioned by many healthcare respondents as an uplifting point of the COVID-19 pandemic. At the heightened outbreak of COVID-19 in May of 2020, the governor of the Virgin Islands, Albert Bryan Jr., announced in his biweekly COVID press conference that he was relaxing his strict entry ban of a cargo ship into the Virgin Islands for one vessel in an attempt to assist a gravely ill sailor. Even more important to note is the fact that other major ports had denied entry of the sick patient at sea, as they were in fear of putting their hospitals and ports at risk with the highly contagious COVID-19. Raleigh Tolentino, a 47-year-old Filipino, spent 5 weeks in a medically induced coma and underwent 12 weeks of treatment at the Schneider Regional Medical Center COVID Center on St. Thomas. He amazingly recovered and was declared to return back to his native Philippines in August of 2020. His send-off was seen as a victory for all employees of the sole hospital on the island of St. Thomas in the Virgin Islands. Jubilation filled the halls of the Schneider Regional Medical Center as he was released. It was indeed a joyous day. Mr. Tolentino stated, "Thank you, God bless you. I can go home to my family," as he pumped his fist from his gurney as dozens of hospital staffs cheered his recovery while the theme song from Rocky played in the background. After a final journey through the halls of hurrahs and clapping and photos, Tolentino was loaded into the ambulance for a medical flight back to his home of the Philippines. This is truly an example of mission accomplished. Thank you for listening. I look forward to any questions or comments at the conclusion of the other presentations. Thanks again.
so much. That was just a fantastic presentation and such a heartwarming and motivating finale. Really wasn't expecting that. So thank you. I do want to encourage our participants in the virtual audience to put questions in the Q&A. We are going to have plenty of time for Q&A at the end, and we have a great panel to draw from experiences. Dr. Lim, please.
Oh, is it actually Dr. Kirsch that's going next?
Sure, I'm happy to go.
Thank you.
If I can figure out all the logistics. Sharing screen. Can you see my slides?
Looks wonderful.
Okay, good. So thank you. I appreciate the opportunity to talk on this panel, this great panel of people, and I'm honored to be here. So from paramedics to environmental staff to nurses to physicians, healthcare workers faced enormous physical, psychological, and moral stressors during the COVID-19 pandemic. Perhaps millions were infected. More than half reported depression, anxiety, and sleeplessness. Thousands died. Almost all kept working. The question I raised for this talk is, what would it take before they stop coming in and everything collapses? So I have to give a disclaimer because I currently work for the federal government. This is my talk. It has nothing to do with my university, the Department of Defense, or the United States in general. This talk is about the impact of COVID-19 on emergency responders, particularly in terms of physical risk and moral harm. Dr. Lim will be covering the psychologic stuff. The focus is on healthcare workers in hospitals, pre-hospital settings, clinics, and nursing homes. But the question can really be applied to anyone in the essential workforce. During the pandemic, we saw issues with meatpackers, warehouse workers, service personnel as others. The most important point that I want to make is that we need to protect critical human infrastructure. And we failed to do that during the COVID-19 pandemic. I dedicate this talk to the perhaps 10,000 healthcare workers and emergency responders who gave their lives protecting others. Throughout this talk, I'll be showing photos like these of those who died: nurses, chaplains, environmental staff, paramedics, unit clerks, doctors, cooks, PAs, and many others. These images are from the Lost on the Frontline project and were collected by the Kaiser Health News and the Guardian newspaper. I'll also be using quotes from responders to help you understand what they went through. Over the past year, the website The Nocturnist collected real-time recorded diaries from healthcare workers around the country, particularly in the heavily hit areas of New York and LA. They spoke about their work, their hopes, and their fears. You may have noticed that I said perhaps 10,000 healthcare workers died. I wish I could be more specific, but we don't know that because no one ever collected that information. Along with James Hodge, I wrote an editorial in JAMA about healthcare workplace safety during the pandemic. OSHA's supposed to count. It's part of their mandate and standard practice. And yet, in May 19th of 2020, just after the first peak, OSHA issued a guideline that said that reporting of healthcare workers' deaths was purely voluntary, and they didn't require it. They said it was just too difficult to determine whether it was work-related, despite the fact that they categorized the healthcare setting as an extremely high-risk environment. Since May 2020, again after the peak, the CDC started collecting data on COVID infections and deaths using a standard COVID reporting form. They asked states to send in the information. Each state did their own collecting. They did their own reporting. It's purely voluntary, and it's highly variable both in the content that was reported as well as the completeness. On July 1st of this year, the CDC reported that there were 514,464 healthcare worker COVID infections and 1,689 deaths. However, They admit in small print on their website that this number is derived from a very flawed sample. In addition to not counting the first wave, these reports represent only a small percentage of the actual numbers. Two flaws. Only 19% of the reports they received included any mention of occupation. And secondly, only 80% of those reports listed whether or not the person died. So let's do the math. Only 1 in 5 reports listed occupation, so the rest weren't included in the tally. That could mean that there could be 5 more healthcare worker cases and deaths, or 2.7 million infections, not 500,000, and 8,500 dead. But when you add to that the incomplete death reporting, as well as the missed first peak and the incompleteness of general reporting, the count could be almost 10,000 healthcare workers that have died during this past pandemic. It's not just possible, this is probable, these numbers. There's been an attempt to count deaths by private organizations and individuals. There's a number of Facebook pages that actually count healthcare worker deaths, as well as some blogs. But the Lost in the Frontline project has really taken the lead in this. 3 months ago, the project, the Guardian newspaper, published that they documented 3,607 dead healthcare workers. They collect cases by simply searching through obituaries and online notices. They don't do it systematically or scientifically. They're only collecting it ad hoc. And they admit up front their collection is an incomplete count. However, their count by the amateurs from a newspaper and a foundation is more than double than the CDC official tally. This is so far out of the norm that it's difficult to fathom. In comparison, in 2017, the last time NIOSH published workplace death statistics, there were only 146 healthcare workers who died the entire year. 146 compared to 10,000 or 8,500 or 3,607. It's really unfathomable. This is probably the greatest workplace tragedy in the history of our country. Now that we understand the scope of the tragedy, I'd like to turn to elaborate a little bit on the risks and the harm. I'm going to get a bit ethical here, so bear with me. I'm kind of like that. I'm going to talk about duties and responsibilities of healthcare workers and of society. I've done a number of studies after earthquakes and flood around the world to address their impact on hospitals and healthcare systems. We looked at the classic disaster planning quadrant of staff, stuff, space, and systems. Always in all my studies, we found that it was staff that was in fact the most resilient. Staff poured in after these events to help. Sometimes, and often, frankly, there were too many staff to actually that were needed. But epidemics are different. From earthquakes and floods, other disasters have little risk to the staff. Infectious diseases are a direct threat to the health of those responding. Why do healthcare workers do this? Well, in addition to their kind of genetic altruistic nature, healthcare workers, especially physicians and nurses, have a duty to care for patients, even at a risk to themselves. Along with the do no harm principle, the duty to care is an expansion of the most basic of all medical ethics foundations, known as the principle of beneficence. It means that we must help and protect each patient we treat. We cannot harm our patients, and we must strive to maximize their well-being. Rationing care is never acceptable. It's wrong. But there are far more categories of healthcare workers than the people in the white coats. Nurses and doctors are just part of a large, intricate team that are all needed to provide care. There is no such duty for other critical positions, such as the technicians and the environmental, clinical, and administrative staff who stand side by side with them in each clinical unit, facing the exact same risks for little of the glory and a fraction of the pay. In fact, it was these support staff and nurses that were the most likely to get COVID and die during this pandemic. Let's go back to the original question. How many healthcare workers must die before responders start coming to work and the healthcare system shuts down? Another more scary and heart-wrenching question is how many of their family members must be sickened and die? During the 2007 SARS epidemic and the 2014 Ebola epidemic, healthcare workers took the brunt of the initial outbreak. Hospitals closed in Hong Kong from SARS. And with an almost 50% mortality rate, hundreds of nurses and a dozen doctors died in Liberia just in the first couple months. The healthcare workers fled, many of them for fear of bringing the disease home to their family. And in the summer of 2014, the entire healthcare systems in Liberia, Guinea, and Sierra Leone closed for over 6 months. What damage does this cause? Can we force responders to quit working to keep working in the face of these threats? Is it their duty to die providing care? What's the duty of the government and society to protect them? This is not a simple question, because an infectious disease risk is not just for the provider, it's for anyone that they come in contact with. Multiple studies have found that the biggest concern among healthcare workers is not getting infected themselves. It's bringing the infection home and infecting their families. Healthcare workers went to extraordinary lengths to protect their families, rarely leaving a separate bedroom in their house, sending their spouse and kids to relatives for months, renting a second apartment, stripping nude in the garage or on the porch, and then showering and washing their clothes before they even enter. No touching their loved ones for months. It is clearly not the duty of healthcare workers, despite their own moral duty, to threaten the lives of their families. Although healthcare workers have a duty to provide care, even under the threat to their own health, there's a reciprocal responsibility from society. It's called the fairness principle. And yet that duty was not fulfilled. Healthcare workers were told they could reuse their PPE. They were told to use surgical masks or even bandanas, despite that everyone knew that those violated even the most basic safety standards established by NIOSH and OSHA. OSHA and NIOSH did not, initially, at least for a year, execute their mandated workplace safety investigations or impose rules on hospitals or nursing homes. They didn't even collect the most fundamental data on worker deaths. Do healthcare workers have a moral duty to risk their lives providing care when the hospitals, the government, and society don't provide them with the reciprocal protections? And then when they're all sick or scared or dead, who's going to take care of my broken leg or deliver your baby? But even more complicated are the risks responding to the pandemic. Those to family and friends and contacts. Should healthcare workers be provided with free housing during a pandemic so they don't have to go home? Extra pay for their risk? Guaranteed sick leave if they get infected? A large insurance benefit if they die? Who's going to take care of the children of a single nurse mom who dies intubated in an ICU? But none of this happened. And in fact, healthcare workers were often punished. Because of the large drop in patient visits and elective surgeries, hospitals lost billions of dollars. To cut costs, they laid off and furloughed staff. Instead of hazard pay, healthcare workers had pay cuts. They lost their bonuses. Their retirement plans were frozen, and they lost their jobs. Let's turn to from health risk to a more hidden harm that healthcare workers in particular have faced. I'm going to plunge back into ethics here, but this time to really spice things up, I'm going to add a little bit of moral neuroscience and psychology. As I mentioned, the core ethical duty of physicians and nurses is to help and protect each patient they treat. We must do what's best for them, always acting in their benefit. We cannot ration care. American providers never face this dilemma in normal settings with a well-stocked, well-staffed hospital with sufficient equipment, supplies, and ICU beds. But that all changes in a catastrophe like the 2010 Haiti earthquake, or another large urban earthquake like the new Madrid or Cascadia scenarios, or a nuke, or a pandemic that may have a mortality of 5% instead of 0.5%. In these cases, there will be too many patients and too few resources. Beneficence is thrown out the window, and I have to become a utilitarian ethicist at this point, choosing the greatest good for the greatest number of people. And that means choosing who gets to be treated and potentially who dies. I faced this horrible decision in Haiti during the Haiti earthquake, trying to provide care in a sweltering tent to thousands of people who poured in every day into our compound seeking help. I violated my duty. Choices had to be made. People died. And a decade later, it still eats at me. The problem is that healthcare workers don't just have a duty to their patients, they have a relationship. We know them, we know the intimate details, we touch them, we care for them. What happens when you've been treating someone for hours or even days before you find out that there's not enough ventilators or antivirals to go around? My oath, my duty to care for my patients suddenly lies in rubble at my feet. Someone is not going to get care and they may die, and it's my choice. The human brain is wired to recoil at the idea of causing harm to any human with whom you have even the most tenuous connection. The way we make life and death decisions is described by what's called the trolley problem in psychological and neuroscience research. It's a moral dilemma used by scientists and psychologists and philosophers in which you must choose to virtually kill one person in order to save 5. There's 2 variations on the theme. One, you can flip a switch, which causes the train to change tracks so that it doesn't run into 5 people, and instead it runs into 1 person and kills them. 2, you can push a person off the bridge who falls in front of the train and dies, but it protects the 5 people down the track later on. So the obvious utilitarian answer to all of this is save 5 people and not 1, right? I mean, doesn't that make sense to everyone? The interesting thing about these studies almost across the board, and there's been dozens of them, is that people are willing to flip the switch to act indirectly, but almost no one is willing to push a person off the bridge. Even that small connection of a touch makes us recoil in our decision-making. The psychologist Joshua Green concluded that humans use reason to make utilitarian decisions and choices when acting indirectly, like flipping a switch. But harming someone you're connected to, even by just simply touching them to push them, elicits a powerful emotional, pre-rational response that overrides cognitive abilities. Moral psychology research by Jonathan Green, Gene Decity, Jonathan Haidt, and others have found that ethical judgments are mostly automatic. We make them with our most primitive brain. Rationally overriding them is difficult. In a sense, harming someone else directly violates a fundamental principle wired into our brain. We can reason all we want post hoc, but it's never possible to erase that decision. And it often leaves a deep sense of emotional guilt and regret. Healthcare workers, nobody should ever be forced to make these choices. That should be left to someone, or preferably a committee with no connection to the patients to decide. During the COVID response, many hospitals formed committees whose sole assignment was to review cases to decide on treatment and to potentially ration care. They should review these cases carefully using well-described criteria, and then they should hit the switch, not the provider who has the personal connection. They should be the ones that toggle the ventilator to Jane and not to John, and leave him on a face mask to struggle and hopefully survive. In conclusion, it's not only society's duty to protect healthcare workers and emergency responders, it's critical for the health of all of us. Studies after the Ebola epidemic in Liberia estimated that there were more deaths from routine healthcare problems, malaria, pneumonia, childbirth, injuries, than there actually were from Ebola because the healthcare system had shut down. How many hundreds of thousands would die if our hospitals, clinics, and nursing homes close, if food delivery stops, if the power grid goes down? COVID was a warm-up. It was a minor little virus with an infection fatality rate of 0.5% or less. And yet, 610,000 Americans are dead, and maybe 10,000 healthcare workers. SARS kills 9%, 20 times more than COVID. Ebola kills at least 40%, in some places 50%. What mortality rate will lead to the collapse of our healthcare system? When will providers flee? But how about the other critical infrastructure, human infrastructure? How about warehouse workers who supply us with food and toilet paper? The utility workers who keep the power going? The police who protect us, or the fire? These scenarios need acknowledgement, planning, training, and supplies. We're pretty good at planning for stuff and space and systems, but frankly, staff has received far too little attention, especially when it comes to disasters, with ongoing physical threats like an infectious disease or even a radiologic event. And more recently, as Dr. Francis discussed, the long-term and serial responses that drag out for months and exhaust our responders. Essential workers are just that. They're essential. They're not sacrificial. They are critical infrastructure. Healthcare workers, emergency managers, clerks, cops, truck drivers, electric line workers, and many others must be protected, or everything falls apart. The threat is real. If we don't protect them, the price would be almost too high to pay. I want to leave you on a more positive note, like Dr. Francis. The good news is that the vaccines have made a tremendous difference. Deaths among healthcare workers have decreased somewhere between 95 and 99% since January, when we all started getting vaccinated. And it's going to continue to protect us. But more interestingly, and finally, the surveys that I quoted, finding anxiety and stress and depression, also found something very interesting. More than 60% of healthcare providers who responded to these same surveys reported a deep sense of meaning and purpose in their COVID work. They are selfless heroes. We, our society, must protect them. It's our duty. These are some essays that I wrote on the topic, if anyone's interested in exploring more, and there's quite a bit out there in publications. I want to thank the workshop, the Natural Hazard Center, for the invitation to discuss this issue, and I look forward to your questions. And let me see if I can figure out how to get out of this.
Thank you so much for that very sobering reminder of, the people who have been working to save our lives and have lost theirs. We really, really appreciate that. It would be great if you could put some of those essay links in the chat so people can easily access them. We would really appreciate that as well. Sure. Thank you so much. We're going to hear from our third speaker.
Dr. Lim, you're going to have to kick me out.
You're going to have to grab the share screen. Thank you so much. We're going to hear from her, and there are lots of questions and comments coming in, so continue to bring them in and we will address them following her presentation. Thank you.
All right. Thank you, Robin. And thanks to Robin and Lori and Jennifer and everyone and the team for inviting me. And thank you to Kula and to Tom for their wonderful and thought-provoking presentations. So I'll explain a little bit about my background. I'll say from the beginning, I am not an expert in emergency management, disaster planning, even disaster psychiatry. I am a psychiatrist, but that's not been necessarily my sort of area. And so what I'm going to be talking about is sort of practically speaking and thinking about all the different things that Drs. Francis and Kirsch talked about is, what are something practically that we did at one healthcare system, my healthcare system, Mount Sinai, to try to, if not prevent, at least mitigate burnout, stress, anxiety, depression as much as we could for the employees in our healthcare system. As you can see, I basically changed jobs a couple of weeks ago. So what I'm talking about is the work that we did last year, predominantly during the peak surge of the epidemic. Oh, okay. All right, so just to give everyone a little bit of background in our healthcare system. So we are a very large healthcare system in New York City. We have 8 hospitals, mostly in three boroughs in New York City, as well as Long Island, multiple schools. We have a huge ambulatory network. We have a very large number of employees, over 43,000. We have over 3,900 licensed beds, the majority of which were filled with people with COVID during that peak surge of basically April, May, and June. And in addition to that, we were very fortunate and also a bit unusual in that we also have a very large behavioral health service, which I was overseeing at that time. So we have 800 FTEs, and so it's a very large service. And you think, wow, that's a lot of behavioral health workforce. I would say I was so grateful to my staff and all my clinicians, but even that still wasn't enough. So what I'm going to be talking about is what we developed as like a plan basically and actually implemented during the peak surge time, and sort of really practical things and things that we learned, things that we did that may hopefully be of help to folks as unfortunately it sounds like other states may be going through surges again or in the future. If there's, God forbid, another type of crisis, whether it's an infectious disease or not. So in trying to think about what we needed to do to support our 43,000 employees of all different types of positions, all different disciplines, multiple locations, in a very large and complex healthcare system, there was a group of people that got together to try to figure this out. And we had to figure this out in like 1 to 2 weeks, essentially. And we agreed upon the following, that the key components of the model needed to address the following. That, unfortunately, the traditional method of providing support during disasters, which is really in person, that was significantly limited for obvious reasons. And yet we couldn't say there was going to be no in-person support. So we needed to figure out how we're going to weave that in and overcome that barrier. We also wanted to make sure that we had a broad array of options for support, that we couldn't have a one size fits all, and we couldn't just wait to have basically interventions that waited for employees to reach out to us. They didn't have time. They didn't have the physical time, the physical energy, or the mental energy to reach out. And so we needed to go out and try to engage people as much as possible instead of waiting for them. We also thought it was important, if possible, to make sure that the interventions were interconnected in a meaningful way so that it would make sense to some degree by employees, that it's not just like a mixed bag of different things that people could use, that there was a rhyme and reason basically to the different services, and that even the best organized model and plan can still be very difficult to understand and navigate. And so we thought it was really important to have a dedicated sort of resource navigation tool and assistance for our employees to help figure out what they need during the surge. So this is what we ended up coming up with, and we called it basically this 5-tier model of employee emotional support during COVID. And the way it was organized, it was literally 5 levels or 5 tiers. And it goes from the most sort of immediate and the most acute and direct, the immediate crisis response, to level 2, which is more the proactive outreach and prevention, psychosocial support, self-care activities, and level 5, which is the resource navigation, which is really not a level per se, sort of helps connect the first 4 levels, but we included that for simplicity's sake as level 5. I'm going to be focusing really on these 2 programs that we developed. These are the programs that were run out of the Department of Psychiatry, and not to diminish the other support options that were there. And there were so many other things that are not included in here that were set up for the employees, all different types of supports. But these are the 2 that I'm going to be focusing on. So just to sort of give a little bit of background, sort of, why we did this is, we have been working in the Department of Psychiatry with New York City and New York State mental health agencies for several years on enhancing and refining their community crisis response system. So that we thought that the sort of basic principles and models and interventions that worked out in the community may be applicable here, in the sense that we've got this large community of 43,000 employees that we needed to reach, basically. And so I pulled the team working from that into this. And so I'm very grateful to them for putting this together with me. And so we came up with this immediate crisis and the proactive outreach. And so I'm going to be describing these crisis response teams. And then for select services, we created something called mental health liaisons, as well as on-site rounding. And that's what we call mental health PPE. I want to thank, many of you may know Craig Katz. He's a national disaster psychiatry expert. I like to say he came up with the term mental health PPE before anyone else did, but he really helped us conceptualize this program in particular. And I'm really grateful for him for all his support. And so we actually wrote this up. If people are interested in reading more about it, it's out there if you want more details. So the crisis response teams, basically what we call MHCRT, involves 2 main things. So we've traditionally set up call lines when there were major adverse events or major crises in the hospitals. They were rarely used. We usually got like 1 or 2 people calling, per day at most. But we knew that we needed to have it just in case. And so we did set up these call lines, and we set up multiple call lines for people to call. And so the difference with this particular model and why it's called a crisis response team is that in addition to staffing the call lines, what these team members did was that they actually provided acute post-crisis group debriefing or support sessions for units or services. So if a staff member calls from the unit, and most often it was because someone had died, usually a fellow staff member had died on their unit, in the very unit that they work on, from COVID, we could actually dispatch people either virtually or in person to provide immediate support, along with other team members from the chaplaincy, for example, or EAP, to help provide immediate support right then and there. So again, we try to put in, not just waiting for people to call, but yes, we needed to wait for people to call, but if they call, we take action basically, and that we provide another level of outreach and provide another level of support beyond just an anonymous person on the phone. And so all of this, by the way, all of our, Department of Psychiatry clinicians, they volunteered to do this. They were all working. All our services were completely open during that time. So they did this on top of their usual day work. And so I'm extraordinarily grateful to them for all the work that they did. This group, for example, they took a week of call, basically. It was back in residency. They took a week of call. So a group of people did that. The next program, which is that level 2 proactive outreach and prevention, was something that we called mental health liaisons. And what we wanted to do was for certain units and services where we knew that we thought that people would be experiencing the most repetitive, the most critical sort of crises and traumas, we wanted to have dedicated teams for those services and not necessarily just wait for them to reach out to us, but to make it known to them that we are here for you and we're dedicated to you. So we created teams of mental health professionals, psychiatrists, psychologists, social workers, counselors, and we basically had about 2 to 3 of them per team, and each team got several units or services that they were assigned to for proactive outreach. And what that meant was they got in touch with the unit leadership, they introduced them to the program, what it was all about, engaged the unit leadership, and then with the unit leadership basically connected with the staff that's assigned to that unit and offered to the staff 2 main things: that they are available by text, email, phone support, totally confidential, basically Monday to Friday, 9 to 5. And in addition to that, to have regularly scheduled group support sessions on the unit for the unit employees, basically. This was quite an undertaking. We had, by the end of it all, we covered 80 units in all. And a lot of the units kept changing because some became COVID units, some were not COVID units, even the leadership was changing at times. So logistically, it was very complicated. But I had a wonderful team working on this with me, so we were able to do this pretty efficiently. We also incorporated this on-site rounding, which was critical because, again, text and email and phone, that's great, but people really want to see people in person. And in the beginning it was a little rough, trying to get people to go round in person. But as time went on, more and more on-site rounding occurred, and that was very, very well received. The other thing that we noted was that, we had organized this according to units, primarily to help make it organizationally efficient. It was easiest to go by geography. However, as Tom noted and as Kula noted, many of the people who were experiencing this, the trauma was not just the nurses and the doctors on the unit or the other medical staff on the unit. It was patient transporters, security, housekeeping, and they're not assigned to a unit per se. And so we created separate teams just for them, so that they had people that they could reach out to and connect with on a regular basis if they wanted to. And so, as I mentioned, a lot of the work that we did, initially, it was by phone and by email and by text. Everyone gave out their own cell numbers. Nobody had a problem with it. They were just all into it. They were very much on board with this. But people were on email and Zoom overload. And there's just so much information that was coming out like several times a day about something new. And so we reverted back to good old-fashioned paper. And this, I think, was actually quite helpful because as we were doing these on-site rounds where we would check in with the units, check in with the staff, we would also explain to them what this program, as well as the MHCRT, was about. So we created unit posters. We put, nice smiling, friendly faces of psychiatrists and psychologists to hopefully, push aside any fear of like, oh my God, I'm going to be talking to a shrink. We emphasize to our clinicians that you are not functioning as a psychiatrist right now. You are functioning as really frontline support. This is not, we're not going through psychoanalysis here. We're not doing psychiatric treatment. This is really support. And so we advertised and doing the advertisement and engagement at the same time. We also created these pocket cards, which had some unexpected effects where we ended up, we created this to assist in our communication. But what ended up happening is that a lot of people use this for other things. So we heard, for example, that one nurse actually would keep it in her pocket. And when she felt it in her pocket, she would remember, oh yeah, I can call these folks if I ever needed to. I never called them, but I knew that they were there if I needed them. Another person told us that she put it on her refrigerator door, and every time she looked at it, it was like a mental reminder to like take a moment, step back, breathe. And so these pocket cards had this sort of really interesting effect of being, again, these sort of reminders. And so, once we engaged with the units and people were engaged and knew about the programs, what the MHLs did was, as soon as an employee reached out by text, email, or phone, what they would do is they would continuously, every couple of days, sort of just check in with them unobtrusively, gently, and just make sure that they're doing okay. And there were some MHLs for whom they had communication with the employee for the duration of the surge that we were there. And a lot of times, a lot of the work that we were doing were supporting the unit and service leadership, which I'll get into later on. In terms of just volumes, really quickly, as I had said before, these crisis call lines tend not to get a lot of volume. So there wasn't a whole lot of volume there, which was what we expected. The MHL program, we did have a significant amount of volume in 3 months. In the beginning, most of it was us initiating the contact. We literally wrote down every single text, email, phone conversation that people had, and just in a log, no content, of course. And then over time, as our staff and the unit leadership understood what this was about, more and more of these contacts were initiated by the staff and employees, and more were more for continuous outreach and engagement. We also did a lot of in-group sessions for the units and services, as well as for other employees. So that worked out pretty good as well. In terms of the things that we heard from and what we experienced overall, these are sort of like the main themes that we heard about. So things that impacted support seeking. There were a lot of logistical barriers, and I don't want to diminish them because they were real logistical barriers. Again, a lot of people were just tired of another Zoom meeting. Even though we offered group Zoom meetings, because quite frankly, that was often the only way that we could do it. A lot of people, just were tired of having another Zoom meeting. But I think, sometimes logistical barriers can be, a sign for another barrier. As a psychiatrist, I have to say that. And so I think a lot of the barrier was the stigma of mental health still, and speaking about emotions, period. And so I do think that one of the great things about both of these programs, as well as the whole plan we implemented, I do think that this sense of openness about talking about emotions, if not mental health, but at least about emotions, I think that was a little bit easier for a lot of people to talk about in the workplace, which is not something we typically do. As I said, the on-site rounding and checking in was really valued. And the fact that people didn't necessarily need to use the service, they just needed to know that it was there for them if they needed it. The presenting symptoms, again, not unexpected. Fear, panic, anxiety, sleeplessness, anger, disbelief, and frustration. All of those were very commonly reported. But in terms of sort of triggering events, well, what were the reasons why people actually finally made the call, were usually in the beginning this fear and panic about not having enough PPE. As time went on, it became more about, as other speakers noted, about, am I going to transmit this to my family? Tremendous fears and anxiety about that. And of course, then there's an acute crisis that occurs on the units when there was a death or even an intubation of a staff member, because that unfortunately meant that the risk of death was very high, or of a young child. And so those are the kinds of reasons why people would call us. In terms of key learning points, the unit service leadership really needed the MHLs just as much, if not more. And really, they needed our support as the managers of the front line. It was so important to help them and listen to them. The importance of senior and executive leadership. We're very fortunate. Our CEO and our dean are psychiatrists. Even then, it's still difficult for people to talk about mental health and emotions, but they talked about these programs. The presidents of the hospital talked about the programs. It were essentially all our senior and exec leadership were actually begging people to seek help and to seek support, that there's nothing wrong with that, and they wanted them to do that. I know I'm going to run out of time, so I'm just you can sort of read about some of the other things that we did. I do want to emphasize how important it is to support the supporters. The people in my department could not use the MHL and MHCRT. So I needed to make sure that we were supporting our department staff. So we characterized this for them. We gave them a meaning and purpose, as Tom noted. This is a humanitarian mission for our work family. This is what we can do. And we checked in with them regularly. My senior leadership, we regularly rounded with them. We did group supervision, individual debriefing, all that kind of stuff. I'm going to skip over the treatment utilization. I'm happy to answer this in the question and answer session, but basically we had a tremendous uptick in employee utilization of our actual mental health treatment services during the later months of the pandemic. And just quickly, post-COVID surge, we basically we couldn't just take away everything. So we created something called warmth teams. I know it sounds a little hokey, but people liked it. And so what we took was, we took the key portions of the MHL and the MHCRT, and we created just one team per hospital of mental health professionals, again, all voluntary, and they do the on-site rounding, checking in with staff, and they also provide crisis response if and when necessary. So sort of melding the two programs, but to do it in a more manageable way over time. The big thing that we've created is this whole Center for Stress, Personal Growth, and Resilience. I think it's a one-of-a-kind center that exists. I have some information about it if people are interested in it. This is for all of our employees. It's a number of different offerings. A big part of it is formal training in resilience. Our dean is actually a resilience and trauma expert, and he wrote this book called Resilience, The Science of Mastering Life's Greatest Challenges. And basically the center has adapted the material in this book into actual training sessions to hopefully help our staff cultivate and develop these resilience skills. And this is more information about the center. And finally, to conclude, I think, we're in the midst of struggling through many different things now. Last year, there was one source of trauma. It was this virus. Now there's this compounding of trauma over the past several months to years. We've had the death of George Floyd. We have all this violence towards people of color. We have hate crimes. We have natural disasters. And it's very difficult now when we have so many different sources of ongoing stress and trauma, which makes things like the center hopefully something that will be helpful for folks. But this is something that I think we're all struggling with. Of course, the impact of the workforce shortages, and how do we prevent people who are staying with us, from leaving and burning out themselves. Concerns about the new surges. And interestingly, as Tom said, and I'll end with this as well, is I think, sort of philosophically, it's, how do we help our employees and help ourselves find sort of a redefined meaning and purpose and will amidst chaos, for lack of a nice word to put it, basically. How do we do that, particularly in the workplace, when there's so many, there's an onslaught of issues for all of us? How do we do that collectively and individually? So these are the kinds of things that we're talking about and struggling with now. I hope that, some of this, stuff in here may be helpful to you all. You don't have to create this whole big program. There may be little interventions or smaller scale things that I think can easily be replicated elsewhere. Doesn't even have to be a hospital system. It doesn't have to be all mental health professionals, actually. So I'm going to stop here and turn it over back, I think, to Robin, so that we can start the question and answer session. Thank you all so much.
Thank you again for yet another fantastic presentation. This has been quite the panel. We actually do have a number of questions, and I am going to start off with a question that kind of mixes each of your presentations, and I'm going to ask Dr. Francis to start her answer, and then if other people want to add to it, please do. So, Dr. Kirsch talked about a moral duty to protect our workers, right? Our frontline workers and others who are saving the lives of people. It seems that at Mount Sinai, you actually had a built-in support system. We're able to do some of that, at least for the behavioral health aspect. But what happens when the power goes out for 4 months, right? What happens when all of your resources actually are lost as a result of the disaster? So, does your moral obligation go away? What happens when you actually don't have 900 psychologists available to support your work? And so Dr. Francis mentioned that, their entire infrastructure was gone as a result of Hurricane Maria and Irma. And so I'm wondering from her perspective, and then we can transfer it to the other speakers, how do you address these moral dilemmas when the problem isn't one that you can control, and what could you do 2 to 5 years from now to help begin to address things that become out of your control? Like, how can you control the uncontrollable?
Excellent question. It is very difficult living through a disaster. Having lived through these disasters myself, I can tell you that it is actually a full-time job, just living through the disasters. So when you think about what frontline workers are actually dealing with, we really have to give them credit for the amount of endurance that they basically show us. In the case of hurricanes and not having power for months, even within my own household, on a daily basis, securing food, ice, standing in lines for gasoline, for generators for the next evening. These are things that took hours. And obviously, I think our frontline workers have to have support systems, because it would be impossible for them to be able to do all that is required to survive and do the job. So they have to have additional resources in terms of family members that may be able to stand up in a line to get water for the day, or stand up in a line to secure gas, or whatever the case may be. And I think support, we've heard that from them, that if they could just get some additional support from the office, the agencies, it would make a big difference on their lives.
Thank you. Would anybody else like to add to this question? Answer? Tom?
You want me to deviate into ethics?
Well, I do. I took Tom's ethics course. That's fantastic. If anybody has an opportunity to think about it, I have a lot of questions that relate to some of those things. But yeah, so you talked about a moral duty, but what happens when it's...
So the issue is, we knew that a pandemic was a threat. We've discussed it as a scenario for 2 decades or 3. We've been through the little ones and stuff. And despite all of that, we did not prepare at national, state, or local level, or the hospitals, or the private sector. That means you're violating your moral duty. When you know there's a risk out there, and when you know you have to support critical infrastructure. Because again, if the electrical people quit coming to work, the power goes out, and the riots start, or whatever's going to happen at that point. Society could collapse. This is critical infrastructure to the nth degree. And so our society, if we want to maintain our society during a big event, and again, if we have a pandemic that kills 3% instead of 0.5, that's a minimum of 2 million people dead over the course of 12 months. We're going to have some real problems with even delivering food to the stores at that point. So it is a moral duty. It's a logical duty. It's a societal duty. We need to prepare and protect our critical responders, no matter what service sector they work in, because this is going to happen again, and it's going to be a big issue for us.
Thank you for that. So I did notice that there are actually some questions that you answered in the chat box, but I thought maybe it'd be be interesting to hear your broader answer to this. And the first one is a little bit technical. It has to do with reporting deaths. And, I kind of want to add a little twist to that. We actually are doing a large mortality reporting study at CDC, in particular, disaster-related deaths, focuses on disaster-related deaths. But sometimes one of the challenges that we face, and I'm interested in how this kind of interacts with what you're talking about here, and some of the things you talk about in terms of federalism is, how does the jurisdictional differences in reporting influence the way that we think about these technical questions like reporting numbers? It's not a simple answer. So you can maybe go through how you answer the question. Yeah.
I typed in an answer to that, but you're the bigger expert than I am. But I can talk from the perspective of a physician. I fill out the death certificates. I'm used to it. I've been doing it for 30 years. And I can say up front, people keep saying, oh, these COVID deaths don't count and they're all ridiculous. And it's not true. I fill out the exact same death certificates. If someone comes in and they're dying from hypoxia and their COVID test is positive, they're a COVID death. I don't care if they have heart disease, cancer, dementia, anything else. The proximal cause, the primary cause of their death is COVID. That system has been in place in America for 100 years. We did not change it during COVID. We fill out the death certificates the exact same way. And just because there's contributing factors, they're obese, they have COPD, we fill out the death certificates the same way. When someone dies from pneumonia or influenza, not during COVID, and they have obesity, COPD, hypertension, et cetera, their death is still from pneumonia or influenza. It's the exact same way. It didn't change during COVID. And then the other thing I pointed out that's critical, the excess death studies that have been published, and there's been a numbers of them, I could post the links, show that during the COVID response, the early studies, we maybe missed, there's 20 to 40% more excess deaths than were reported as COVID deaths. So somewhere in the past 12 months, there's been between 800,000 and 1 million more people died than was predicted than the standard deaths for the last decade. These deaths are probably COVID deaths. And there's been some elegant studies that have tried to tease that out, that look at the death certificate causes and stuff and see if it's pneumonia versus hypoxia, whatever. And so COVID killed at a minimum 610,000 Americans, and more likely closer to 1 million Americans so far. And again, you're the expert. I'm just a simple country doctor.
Thank you. Just for the record, I'm a developmental psychologist for all of you out there, but I've been at CDC for quite some time. So each one of you talked about a slightly different group of responders. And I come from the field of public health, and we also think about our public health responders, the folks who are out there doing contact tracing, the folks who are developing communications, all of the folks who are developing guidance, et cetera. There's a lot of different ways to think about and define responders. And Dr. Lim actually pointed to a lot of people we might think about in hospitals, people who are cleaning, who might have to do a 24-hour shift, and they never expected that before. So when we think about responders, we have a question here that says, what are acceptable losses? What have we actually lost when we've lost not just a doctor or a nurse, but the only person who understands our epic, code to enter patient information? What happens there, and how do we process that, and how do we think about that? How do we think about that in a U.S. territory where there really are so few people with high level expertise? So anybody can answer that question, but that really kind of gets to this acceptable loss issue or replacement of loss. And this is not just, I think all the time about tsunamis, it just washes out entire communities. This is not just about COVID. It clearly goes beyond COVID. Maybe Dr. Lim can start with that one.
I think this quote simple answer is that there really is no acceptable loss. As Tom said, that it should not be a given that because, and whether you're a doctor or someone who's a registrar, or whether you are transporting a dead body, no one person's life is more valuable. And I think it's important, to characterize that and say that in an authentic and genuine way. We can't, and I think one of the things that I think learned from this, at least at Sinai, is, really striking, whether it was a doctor or whether it was the secretary who died, the loss people had was exactly the same. It isn't any less painful, right? It doesn't matter what they did. And so at least on a day-to-day basis and amongst ourselves, if we can sort of recognize that and accept that's important. But I think at least the way I think about it, there is no acceptable loss. But Tom and Kula, please. I think in many ways, I'm very fortunate. And even though New York was the epicenter, we had tremendous resources. There's no question about it, right? And so, I recognize I'm sort of speaking from a particular area where we were very resource intensive. And so Kula, I wish I'd met you earlier because I think it would have been wonderful to talk with you before. Tom, certainly we've met, and you were so helpful to us in sort of thinking about our whole program. But it opens up your eyes even more to see beyond your own little bubble of what can be done and what's needed.
I think that's actually an excellent thing to think about, and something we think about in our office is, how can we borrow from what you all have learned now to improve what everybody can do 2 to 5 years from now. And so we are absolutely thinking about responder resilience. So I'm going to actually read this whole stream that's in the chat box. It is has a question at the end of it. So, just wait for it. Burnout has historically been characterized in the US as a kind of thing that could be cured by a week on the beach or a national park. But our speakers are bringing up realities that no amount of beach time can cure because burnout is becoming our norm. How do we denormalize the expectation to feel exhausted and continue working anyhow? And do our panelists think that recent job change quitting increases in the US could be a sort of correction to or backlash to the experience of more general burnout? Let's start with Dr. Francis, because I can't imagine what's happening there in the Virgin Islands right now.
I think that question needs to look at it from a policy perspective. And I think that until agencies, the government, organizations look at the fact that we need to hire additional employees to curtail the burnout, it will continue to happen. So until we figure out a mechanism to have additional persons in place, even if on a temporary scale during disasters. For example, in the Virgin Islands, between June 1st and November 30th, we're in hurricane season. So hurricanes can happen at any time in that time frame. Knowing this and knowing that we are seeing more and more storms, it would be a wise decision to have additional personnel in place in the event that we need them in the event of a disaster. So I think we need to look at it from a policy perspective and have additional individuals who have the power to make change actually start making them, rather than assuming that, well, if we give them a week off, exactly as the commenter said, if we give them a week off on the beach, they should be fine. It does require more than that. And I think additional hands on deck would be one of the greatest starts.
Thank you. So there's another question here that talks about managing emotions, putting emotions aside as people perform work. And this is for perhaps Dr. Lim and Dr. Kirsch. There's also been a lot in the news lately about frontline workers refusing to get vaccinated. So when we think about our own, like the individual frontline worker, the person who really is under pressure at that moment, their own moral responsibility, how deep does that go? Maybe they're responsible for getting vaccinated, maybe a huge religious issue there. But can they actually be responsible for controlling their emotions in the face of trying to deal with 100 patients at the same time? Like, where is the responsibility for the individual, especially if they're not trained for this level of crisis?
So Dr. Lim, is Mount Sinai going to require employees to get vaccinated?
We have not done that yet. We are doing everything and anything possible to encourage and use motivational interviewing style techniques seriously, I told you, we have psychiatrists who run the ship to really encourage people. And, people aren't getting vaccinated for a whole host of reasons, very similar to what's happening in the country. I think at least for us, we've acknowledged that it's hard. You can't always control your emotions, and it doesn't mean that you're weak or you're a bad person, and that it's okay that you can process your emotions at work, and that's actually healthier for you, and you can feel better, and you can probably do a better job if you can do that. But I think, even with that, I think people are still, and I think to get to Kula's point about the burnout and taking a week on the beach or whatever, there's so much that there's not enough self-care. Self-care ain't gonna cut it. MHL, it's nice, but it's not. There has to be practical solutions, like increased staffing, managing the EMR. Before the pandemic, everyone was talking about how the EMR is really difficult for folks, and there has to be really practical changes beyond just the emotional support. But at the same time, recognizing that you're not a weak person, or there's something, or you're a bad doctor, or you're a bad person if you show that you're upset or you're angry. It's how you work through it that's more important.
I'd like to add on that as well. The Virgin Islands actually right now has one of the lowest vaccination rates in the nation. And we need to think about or consider the fact that the population of the Virgin Islands is almost 80% African American. And unfortunately, many of those individuals that fall within that group are those that are most at risk of dying from complications of COVID-19. So it is a very touchy issue. On top of that, the University of the Virgin Islands, the only institution in the Virgin Islands of higher learning, actually just put in place a mandate or requiring all faculty, all staff, all students to be fully vaccinated by fall of 2021. And of course, as you could imagine, it has caused a lot of uproar within the Virgin Islands.
So thank you. I'm going to ask another question and I'm going to add another angle to it again. I'm sorry, we just talked about requiring vaccinations, and we're going to think about mental health care, behavioral health care. So one of our questions is, healthcare workers are already under intense stress and experience burnout during peacetime when they're not facing disasters personally and professionally. How can we normalize mental well-being support and adapt crisis interventions to assist people before they find themselves in crisis, and to deal with work and life challenges we all encounter? It's like a mental health vaccine. How can we normalize this, Dr. Lim?
Oh, I wish I had the answer for that. But I think, the first step is for, so much of the issue of mental health is that no one wants to talk about it. So the first step is you've got to talk about it. And it's important who talks about it. It can't just be the psychiatrists talking about it. It's got to be people. And it helps a lot when there are people who are in leadership positions. So we have, for example, we have a series at Sinai where there's an ongoing series of conversations for different leaders, middle management, upper management, and there's specific topics. So one of the topics is basically about this. And we have senior leaders who come in and talk about, I had depression. I was in treatment for depression. It's okay. And he talked about all of those, and sort of recognizing that there's no shame or embarrassment, and putting it out into the open, I think is the first step. I think beyond that, if you can't even go there, then we're continuously basically hiding in the dark. After that, though, I think as soon as you open that up, you also have to think about, even before you open up that, you got to make sure that you provide resources, behavioral health, and that's a huge issue. That was an issue for decades, and that's a big challenge. But so I would, try to think about, before you open up that door, make sure that you have resources, if possible, for your staff. But still, better to just start at least talking about it, and make sure people who are well known and hopefully willing to talk about it will talk about it.
Yeah, that stigma in mental health care has been around for decades, for centuries, perhaps. It really, and certainly many cultural barriers to consider and cross over, and not just whether or not somebody's going to seek care, but from whom and what type of care. And so definitely something that we have to deal with going on. So I'm wondering if any of you have questions for each other. Put you on the spot.
So, yeah, regarding, it's nice to have Mount Sinai, and the work that Dr. Lim did, because I watched her do it during the outbreak, was tremendous. Can you think of ways that you could adapt that work to other critical personnel sectors, whether it's the electrical grid people or the power people or the cops, or are there tools that you could advance to help everybody?
You know, I think one of the things that we often get asked is, well, you had 100 overall, 100, 200, mental health professionals. It actually, I thought there were many times when I thought it was actually a disadvantage that all of the people who were doing this were mental health professionals. If we had had more time and we could train more people, I actually would, yes, you need a couple of mental health professionals, but I actually would have adopted more of having non-mental health professionals, because the key work that we were doing, which was psychological first aid based, was really, you need to be empathic, non-judgmental, maintain your boundaries, and listen, basically. And if that's your makeup, there's plenty of people in all different areas in disciplines and fields that can do that. So I do think that concept of having sort of a group who, whether it's leadership or not, and sometimes it's better if it's not leadership who regularly does it, to have, a group of people maybe led by one mental health professional, but the rest are, you may even want to think about it as almost like a community health worker model, who are trained and go in and actually provide that sort of check-in support, that unobtrusive, gentle reminders. It doesn't have to be, tech savvy and doing a lot of Zoom things. But again, it's really just knowing and giving people enough reminders that support and we have an ear for you. I think that can be replicated without the need for this whole big program or having all of these, psychiatrists and psychologists on board. It's really an issue of having the time to train people to do it.
Yeah, I think that's excellent. And, just really, not just in mental health, but in emergency management in general, having a very broadly, loosely trained group of folks who are ready to launch, to respond, and add to the standard responding pool would be fantastic. So I want to let everybody know who's not following the chat box that there are a significant number of fabulous resources there, and I hope that they'll get posted in another way going forward. I want to thank the panelists. I want to thank everybody out there who is a responder or on the edge of responding, or just getting through everyday life, because it's still not easy. And hope that if you are feeling burnout, you use this panel as an opportunity to go talk to somebody and do something about it, because we're all at risk of burning out. I'm going to turn over to Lori now, who's going to give you some announcements and take you into the next session. Thank you, everybody.
Robin, thank you so much for stepping in and moderating this session, and for the work that you're doing for this through the Centers for Disease Control and Prevention. Thank you so much, Kula and Tom and Sabina, for sharing your personal experiences, sharing your research, sharing your applications. This was an incredibly powerful and provocative session. And so thank you for honoring us with your presence and for the work that you do. And just to close this session out before we start our morning break, I had a couple of announcements that I wanted to share with all of you. And as always, a special thanks to our workshop participants for being here and for participating in such a wholehearted way. And so first, I just wanted to make sure and point everybody to a special session that we are going to hold this evening from 5:30 to 7 p.m. You can access it through your FeedLoop portal in honor of the former director of the Natural Hazard Center, Dr. Dennis Milletti, who actually perished from complications due to COVID-19 on January 31st, 2021, 2 days before he was set to receive his COVID-19 vaccine. And so I hope you will all join with us so you can share your memories of Dennis and be a part of this special session this evening. So please do join us. And I also wanted to make sure that everyone knows that there is still time to sign up for the Bill Anderson Fund Disaster Dash. We have almost over 100 runners, walkers who are doing their best to get out there all around the world to support this amazing organization that is transforming hazards and disaster research and practice. And with a tip of the hat to Norma Anderson, Nania Campbell, and all of the Bill Anderson Fund students and alums who are with us today. And so please join the Disaster Dash wherever you are. And then I also wanted to remind everybody that all of the books from the new read session and also the nearly 100 posters from our poster session are still up. They're viewable throughout the duration of the workshop. So please, please go over and check out that amazing work. And last but not least, after an intense session on burnout, I hope that all of you are going to step away from your screens for the next 30 minutes and have an incredibly restorative break. And we'll see you back at 10:30 for another great plenary session. Please join me in offering final words of gratitude to this panel and to our moderator. So thank you, everyone. Have a great break, and we'll see you at 30 minutes after the hour. Thank you.